2, 3, 4, 5, 6, 7. Good evening, everyone. My name is Dr. Roxana Chaudhry, and I am the Director of Mental Health Programming for the American Muslim Health Professionals. And today we are discussing a very important issue on the topic of mental health stigma. We are joined together with the Family and Youth Institute, the Substance Abuse and Mental Health Services Administration, the Department of Health and Human Services, and Imam Sahab Sultan from Princeton University to have this discussion. We are hoping that through this webinar and through the end of this, we can tackle and have some ideas about what the American Muslim community can do to reduce stigma and help our loved ones get the care they need. I would like to just say a bit about the American Muslim Health Professionals first. We are a national nonprofit organization focused on professional development, health education, and we serve the unique needs of the American Muslim community, as well as develop advocacy for minorities and underserved communities. A little bit about the other sponsors of this webinar in terms of those that will be participating as panelists and reaching their members. I'd like to say a bit about the Family and Youth Institute. The Family and Youth Institute is a research and education nonprofit that aims to support young people and their families by conducting original research, creating resources, and presenting community psychoeducational programs. The Family and Youth Institute disseminates its work through academic publications, scholarly articles, community bulletins, public lectures, as well as intensive workshops. Also, I would like to say a bit about the Department of Health and Human Services. The Department of Health and Human Services is the U.S. government's principal agency for protecting the health of all Americans and providing essential human services, especially for those who are least able to help themselves. It is their mission to enhance and protect the health and well-being of Americans by providing for effective health and human services and fostering advances in medicine, public health, and social services. The department manages programs that cover a vast spectrum of activities that impact health, public health, and human services outcomes throughout the lifespan. Finally, the Substance Abuse and Mental Health Services Administration is a branch of the Department of Health and Human Services. It is charged with improving the quality and availability of prevention, treatment, and rehabilitative services in order to reduce illness, death, disability, and costs to society resulting from substance abuse and mental illnesses. Today, as we discuss this issue of mental health stigma, we are privileged to have 4 excellent speakers. And the first of those speakers is Dr. Lark Wang. She is a licensed clinical community psychologist, a senior advisor in the Administrator's Office of Policy Planning and Innovation at the Substance Abuse and Mental Health Services Administration. In this position, she provides leadership on national policy for mental health and substance use issues for children, adolescents, and families, and leads the Administrator's strategic initiative on trauma and justice. She is also the director of SAMHSA's Office of Behavioral Health Equity, which was legislated by the Patient Protection and Affordable Care Act. For the past 30 years, Dr. Wang has worked at the interface of practice, research, and policy. She has assumed multiple leadership roles dedicated to improving the lives of children, families, and communities. Most recently, she has developed federal policy documents with the Centers for Medicare and Medicaid Services addressing behavioral health service delivery and financing for child and adolescent mental health and substance use prevention and treatment. Dr. Wang has also developed programs for underserved, culturally and linguistically diverse populations, evaluated community-based programs, and authored books and articles on behavioral health. Then we will hear from Dr. Samira Ahmed. Dr. Samira Ahmed is the director of the Family and Youth Institute. In addition, she is a clinical assistant professor at Wayne State University and an associate editor for the Journal of Muslim Mental Health. Her area of interests include risk behaviors and protective factors of Muslim adolescents and young adults, promoting culturally and religiously meaningful psychotherapy and skills-based parenting and marital interventions to strengthen families. She presents seminars and workshops across the nation in both academic and community settings. She has published numerous research articles as well as co-edited a book entitled Counseling Muslims, Mental Health Issues and Interventions. She has served the Muslim community at the local and national level for the last 20 years, primarily focusing her efforts on youth empowerment. She has held numerous leadership positions within the Muslim American Society at the local and national level. Then we will hear from Suhaib Nazir Sultan. He is the first full-time Muslim life coordinator and chaplain at Princeton University. He's a graduate of the Hartford Theological Seminary, earning a master's in Islamic Studies and Christian-Muslim Relations and a graduate certificate in Islamic chaplaincy. His research and academic interests are in Islamic spirituality and psychology, as well as the development of practical skills in religious leadership. Suhaib Sultan has published his second book recently with Skylight's Paths Publishing, The Quran and Sayings of Prophet Muhammad, Selection Annotated and Explained. He is also the author of several published articles and continues to write for various publications. Finally, an important aspect of this presentation today is that we will hear directly from someone who has struggled with mental health issues herself and will be sharing her story and combating stigma along her journey. This is Mariam Abdul Aziz. She currently serves as a CPS certification coordinator for the Georgia Mental Health Consumer Network. She holds a BS in psychology and became a certified peer specialist in 2007. She is passionate about sharing her own lived experience with a mental health condition and spreading the word of wellness and recovery. She is a wellness recovery action plan facilitator and a whole health action management coach. Ms. Abdul Aziz also sits on the executive board of Aziza Magazine, a magazine for American Muslim women. So to begin with, I'd like to make a note about the topic that we are discussing tonight and a note about the purpose of the webinar. And we decided that we would do this webinar because we understand that there are still attitudes within most societies that view symptoms of psychopathology as threatening and uncomfortable, and these attitudes frequently foster stigma and discrimination towards people with mental health issues. These reactions are common when people are brave enough to admit they have a mental health problem, and it can often lead to various forms of exclusion or discrimination, whether it's in the social circle or in the workplace. So we are really talking about two types of stigma, I think. There's social stigma and, of course, perceived stigma. And the perceived stigma is the internalizing by the mental health sufferer of their perceptions of discrimination. And it can significantly affect feelings of shame and lead to poor treatment outcomes. So this led us to put together this webinar with this excellent panel. And I'd like to introduce our first panelist in discussing issues around this. Specifically, she will talk about her work with youth and focus on trauma. And we have Dr. Lark Wang.
Thank you, Dr. Chaudhry. I'm pleased to be part of this webinar this evening and welcome all of you who are attendees as well as my fellow panelists. So I was asked to, as was mentioned, I'm with the SAMHSA, the Substance Abuse and Mental Health Service Administration, and I was asked to talk a little bit about mental health stigma, trauma, and youth. So in my time, I'm going to try to hit upon those topics. I do want to say I don't have direct experience in working with the Muslim community, so my comments are going to be sort of more general, population-based comments, but I do have some information, a study that just was released on looking at stigma in different diverse populations. So I'm going to actually start with that. Next slide. So this is a study that was done in California, a random sampling of different racial and ethnic populations, and looking at the experiences of people with perceived psychological distress, stigma, and discrimination, and how that plays out across different populations. Next slide. And this was just conducted. These findings were just published actually this month. As was mentioned, there are different types of stigma. There is perceptions of public stigma, and then there is self-stigma. And many diverse communities are more likely than white to delay or forego needed mental health care. And often if they seek treatment, they're more likely to drop out or not stay engaged in treatment. In part, this is due to negative attitudes, beliefs, or behaviors that the public holds towards people with mental illness, which we refer to as public stigma, that may lead people to deny or conceal their mental health problems. When people with mental health problems internalize these negative societal beliefs about mental illness, we refer to this as self-stigma. This can often lead to feelings of hopelessness or the why try effect, where individuals give up on treatment employment, or other important endeavors that are integral to recovery. I'm going to report on some of the key findings of this particular study. So this slide shows that perceptions of public stigma and experiences of discrimination are high across all different diverse racial ethnic population groups. But here, Asian Americans and Latinos, for example, are disproportionately affected by higher levels of self-stigma in particular. Only a small proportion of these groups viewed the public as being caring and sympathetic. Next slide. The study also looked at beliefs about recovery. That is, can people with a mental illness, a mental health problem, move into some kind of sustained recovery? And most groups believe a person with a mental illness who seeks treatment can eventually recover and lead a normal life. Two groups, Asian American and Latinos, believe those with mental illness are not going to be as strong contributors to society. Next slide. Fear of social judgment, rejection, and discrimination may motivate some individuals to conceal their mental health problems or challenges. No significant group differences were found in concealing a mental health problem from family or friends, but there were significant differences in two groups, non-Latinos and whites, in concealing their mental health issue from coworkers or classmates. Next slide. And then, interestingly, all populations surveyed said that they would, in fact, seek professional help for a serious emotional problem. And actually, relatively low levels of population would put off seeking treatment for fear of letting others know about their mental health problem. So, next slide. So self-stigma and discrimination can impede one's recovery and contribute to worsening of one's quality of life. A frequently reported type of self-stigma is alienation, or not feeling fully a part of society or well integrated into society or one's community. Asian Americans and Latino were significantly more likely to feel alienated because of mental health issues. Particularly for Asian Americans, they may harbor more stigmatizing attitudes towards those with mental illness, which in turn may translate into higher levels of self-stigma. So I present this study because you're focusing on stigma, and it's important to look at the different components that go into a sense of stigma or a sense of feeling discriminated against, because they have important implications, these different patterns of stigma among different population and groups in terms of effective interventions for outreach, engagement, and retention in treatment. Next slide. So I was also asked to talk about understanding trauma, particularly trauma in youth, and reducing stigma. One of the ways that we actually have been able to get around stigma, both in our mental health work and in our substance abuse work at our agency, is really understanding the linkage of traumatic exposures or traumatic experiences to mental health and substance use problems and disorders. Next slide. So increasingly we understand that trauma plays a central role in many of the conditions that we at SAMHSA are concerned about. We understand it now almost to be a universal experience of people in the public mental health or the public substance abuse and social service system. We see violence and trauma as having a central role in school problems, incarceration, contributing to homelessness, relationship and job problems, certainly different types of mental health problems, and we're even seeing now more the connections from longitudinal studies looking at early exposure to trauma in early childhood connected with later, more serious psychological disorders in young adulthood and adults. We also see violence and trauma as contributing to substance abuse problems and disorders, as well as parenting problems. Next slide. So these are just some findings from different studies over the years that really indicate the prevalence of trauma in our behavioral health sector. And we consider the behavioral health system the system that focuses on serving people with mental health issues and substance use issues. For example, a survey of adolescents in substance use treatment, over 70% had a history of trauma exposure. We see that youth who are in some of the actually traumatizing systems, such as child welfare, juvenile justice, also report more exposure and significant histories of trauma than the general population. So not only are these youth showing difficult behaviors that may have their antecedents in trauma exposure, but it leads them to involvement with systems, child-serving systems, that are in and of themselves secondarily re-traumatized. Next slide. We find that 1 in 4 girls in this country is sexually abused, 1 in 6 boys is sexually abused. Up to 93% of the youth in the criminal justice system have experienced some form of child trauma. And an estimated 15 million children live in families in which there is some kind of physical violence, some kind of domestic or interpersonal violence. And research shows that children exposed to trauma and violence are more likely to struggle in school, to have behavior problems, feel depressed, and get into trouble with the law. Next slide. As we were really gaining a better understanding of the centrality of trauma in many of the conditions that we are tasked with addressing, we brought experts, research experts, clinicians, and people with lived experiences of trauma to put together a concept paper, an extensive concept of trauma and guidance for a trauma-informed approach, and the link is provided on this slide. This was a key concept document to pull together a lot of the work that's gone on in the research field and the clinical field, and much of our work at SAMHSA is always informed by people with lived experience. So we put this concept paper together to really pull together a lot of lines of thinking that might come out of Veterans Administration, out of NIMH research community, out of the consumer movement and the consumer people with lived experience, survivors of trauma community, and as well as clinical practitioners. They come up with what we define as trauma and what we think is important principles for guiding us toward more trauma-informed approaches in our healthcare systems, in our behavioral healthcare systems, in schools, our primary care system, that we came up with a framework where recognition and addressing of trauma is relevant to better serving the people in that system. Next slide. So in this consensus document, we came up with a concept of the 3 E's of trauma, that individual trauma results from an event, a series of events, the set of circumstances associated with that is experienced by an individual as physically or emotionally harmful or life-threatening, and that in some way has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Oftentimes, people define trauma by different types of events. We looked at different categories that are potential traumatic experiences and exposures, and looked at those in terms of interpersonal trauma, such as physical or sexual abuse, maltreatment, domestic or intimate partner violence, or bullying. We looked at social settings in which we see high potential for trauma exposures, whether they're school settings or community settings, community violence. We also looked at racism and discrimination, and in our department, Department of Health and Human Services, we put out a plan for health called Healthy People 2020, and we're looking more now at discrimination as an infringement on people's health, really looking at that in terms of what are the indicators of that and what is the impact of that on people's health and well-being. Disasters, natural and man-made, can also lead to traumatic experiences, as well as large-scale movements or large-scale events such as war, migration, and refugee trauma. Next slide. So we looked at trauma as a cumulative, that it affects the developing neurophysiological system, that it also increases the likelihood of health risk behaviors, and that it's directly related to mental health symptoms, substance abuse, as well as chronic physical illness and early mortality. This study by Folletti has been a landmark study for us and a number of other agencies in terms of looking at the impact of trauma, because it looked at adverse childhood experiences in a non-clinical population of people enrolled in Kaiser health plans. So the study done jointly by CDC and Kaiser Permanente, and found a direct correlation between the number of adverse childhood experiences, and those were in categories of family problems, abuse, loss of a parent, parent with a substance abuse issue, parent with a mental health issue, an incarcerated parent, divorce, and really just did a count of looking at the number of trauma exposures and the correlation with different kinds of risky behaviors. Next slide. So this slide shows the negative outcomes that are directly correlated with number of ACEs. It didn't talk about the types of ACEs, the intensity of them, but just direct correlation with higher ACEs associated with depression, with smoking, with use of illicit drugs, with later alcoholism, or those who have ever attempted suicide. I put the behavioral health risk conditions up here, but there are also direct correlations with cardiac problems, with diabetes, with lung problems, and other chronic physical illnesses. So it was a key study in the sense of looking not just at the behavioral health issues of trauma, but the connection between also chronic physical conditions. Next slide. The next couple of slides, I'm going to go through them just very quickly. Again, this shows the direct relationship between the number of adverse childhood experiences and chronic depression in adults. There are also correlations with employment, part-time employment, and unemployment as well. So clearly something's going on at these times of exposure that has an impact both neurophysiologically, neurobiologically, in terms of affecting stress, coping skills, and later functional outcomes as well as health and behavioral health outcomes. Next slide. Okay, this is with alcoholism. Next slide. I also wanted to document that in our grant programs at SAMHSA, we also looked at victimization, the rates, severity of victimization as connected with the number of major clinical problems at presentation in our various treatment programs. Again, you see a direct correlation with higher severity of victimization or trauma and violence associated with higher numbers of clinical problems and presentation. Next slide. I want to share with you some information that comes from one of our researchers at the University of Southern California, who's done a lot of work for us through a grant-funded program around trauma exposures in school and looking at interventions for school-age children and school settings for those who have been exposed to school violence or come in with trauma histories into the school setting. And she repeatedly tells us that traumatized children and adolescents display changes in levels of stress hormones similar to those seen in combat veterans. We have many more ways of assessing stress through cortisol salivary sampling, ways that are not so intrusive, ways that are also assessment measures, and in her work both with combat veterans and with school children, she sees similar displays in stress hormones for those exposed to violence. Next slide. So what are the effects of trauma exposure on children and youth? So it affects a number of domains of childhood development and functioning. We see it affecting attachment, which then impairs social isolation, social relationships, having difficulty relating to and empathizing with others. We see impairments in terms of biological functioning, problems with movement, sensation, physical contact, and increased medical problems. We see trauma affecting emotional regulation and mood regulation, difficulty knowing, describing, and feeling internal states. Next slide. We see the impact of trauma on a sense of depersonalization or observing that sense detached from oneself, We see poor behavioral control with poor impulse control and self-regulation. We see impacts on cognition, impacts on attention, on cognitive planning, on cognitive problem solving. And of course, this would then have a significant impact on one's attention and performance in school. And we also see the impact of trauma on one's self-concept in terms of a disturbed self-image, lower self-esteem, shame, and guilt. Next slide. Can you click 5 times? I didn't mean to have all these come in separately. So we clearly know the effects of violence and trauma, that they interfere with learning in school. Often trauma leads to anger, aggression, or it leads to sadness or depression. So in terms of working with school systems, we often say that children who are exposed to violence or trauma, they're often very sad children or very mad children. And so that children who are very sad and very mad obviously cannot add. They can't really focus on school performance. They can't focus on school tasks. They have decreased rates of high school graduation, lower grade point averages, more days absent from school, and more disruption in school through suspensions and expulsion. We see clearly for those youth who have had trauma and traumatic experiences, the inability to concentrate, flashbacks and preoccupation with their trauma experiences, and oftentimes avoidance of schools and other social gathering places. Next slide. Can you click some more? Then show you, yes. So interestingly, schools are looking at how they can become more trauma-informed. We have schools that are becoming trauma-informed schools or having trauma-informed classrooms. We know there's a lawsuit actually out in a class action lawsuit in Southern California with students and faculty bringing a lawsuit against Compton Unified School District in terms of the school inadequately and ineptly handling the high rates of trauma experienced by their students. So we know that in terms of looking at how can one become more trauma-informed in schools, we need to think about early detection and intervention, linking students up with appropriate mental health services, and training teachers, staff, and parents to look at the early signs of response or reactions to trauma exposure, and how teachers and parents can learn how they can support fearful and anxious students in the classroom, and how they can create a sense of both psychological as well as physical safety for these youth exposed to trauma. Next slide. So there are many paths to recovery, and we have increasingly number of evidence-based models and interventions, whether they are therapeutic interventions, whether they're preventive interventions, or whether they are interventions that we now refer to more as a trauma-informed approach, which is creating an organizational culture in which hosts these kinds of interventions and creates a more compassionate and trauma-supportive environment for the young person exposed to trauma. So we have cognitive behavioral therapies, emotion regulation therapies, increasingly more mindfulness-based mind-body therapies, including such things as yoga as well and meditation. And we're increasingly working with peers to do peer-to-peer support programs and understanding increasingly the impact that somebody with a lived experience and a survivor of trauma, how important they can be in the healing process and moving to recovery for young people exposed to trauma. Next slide. Just winding up now. So I want to just tell you about a couple of programs that we have supported at SAMHSA. We support the National Child Traumatic Stress Initiative, which is a major grant program funding researchers, funding academic settings, as well as community service provider settings around the country. And this initiative has led to the identification of and development of screening tools, assessment tools for screening and assessing for traumatic exposure. has worked to develop interventions for different types of trauma exposure for different age groups. So we know that working with a very young child exposed to trauma is going to be very different than working with an adolescent or a young adult. And we know that young, very, very young children can have severe reactions, traumatic exposure. We also know that some of the youngest children have some of the most severe experiences of maltreatment and trauma. So there's a lot of resources in terms of treatment approaches, descriptions of treatment approaches, opportunities to view videos on interventions, opportunities to become parts of online learning collaboratives. And there are some products that are actually specific to the Muslim community, and also some documents and materials that are specific to bullying in the Muslim community. So I encourage you to go to that site. Next slide. This is just a map of our network where we have funded centers across the country. The centers are coordinated by two national coordinating centers that are housed at UCLA and Duke universities. Next slide. And finally, this is just a snapshot of some of the products that are available through the Trauma Network. Bob Pinus, who is one of the leaders of the coordinating center and the founder of Psychological First Aid. We have a manual for doing psych first aid on there, as well as responding to crises in the aftermath of disasters, child welfare work, juvenile justice work, policy work around trauma, and interventions. So I think that is it for my presentation. Thank you very much. So I'm done.
And can we move to
Thank you. Thank you, Dr. Wang, for that rich overview. It's very important for us to get that general sense of what childhood experience is when it comes to trauma, and how we can apply that to the Muslim American community. And I think that would lead us right to Dr. Samira Ahmed. And I want to encourage everyone that is participating and viewing the webinar to send in your questions as often as you would like in the questions box, as we'll be taking those and holding on to those to the very end. So just a reminder that that is an option here. So next we will hear from Dr. Samira Ahmed from the Family and Youth Institute.
Thank you. I begin in the name of God, the most gracious, most merciful, and begin by sending peace and blessings upon His Prophet Muhammad sallallahu alaihi wasallam. Thank you so much, Lark, for sharing the research related to stigma and trauma and the long-term impact on behaviors, as well as the path to recovery. You've actually made my job much, much easier, so thank you. As a clinician, I often work with individuals who are struggling with mental illness. And it's important that we address the issues that Lark talked about because it's one of the issues that really really impacts our ability to get the help that we need. The issue of stigma is one of the major barriers for individuals wanting to get assistance. And what I'm going to be focusing on today are what are some of the contributors to stigma that are specific to the American Muslim community, and what can we as individuals in the community do to address this to help reduce the stigma using religious and cultural resources which would help ourselves as well as our peers. Next slide, please. So just to begin, to make sure that we're all on the same page, when we talk about mental health and well-being, it's important that we define our terminology. So the Surgeon General defines mental health as the successful performance of mental function resulting in productive activities, fulfilling relationships with other people, and the ability to adapt to change and cope with adversity. So we're looking about being mentally healthy, positive relationships, and the ability to cope with whatever comes our way. And this is really the cornerstones of mental health. Yet, many within our community are silently suffering with mental illness. They're suffering with poor relationships and difficulties coping with the trauma, either past traumas or current traumas they're dealing with. And one of the reasons why we realize is because of stigma. It's because of stigma, it's a lack of education, knowledge, and despite the suffering, individuals may choose not to seek treatment because of religious attributions of mental health symptoms, belief that it's related to lack of faith, fear of what people may say, stigma associated with mental illness, not knowing where to get help or how to get help, or even fear of the treatment process and being able to find a culturally competent, religiously competent clinician. So these are some of the barriers. But what happens is when we don't get help, the condition gets worse. It becomes harder to treat, and the recovery process becomes more complicated and elongated. And not only does it have a negative impact on the individual, but it also has an impact on their loved ones, their spouses, children, relatives, friends. It impacts their academic abilities, their work efforts. So it really has a long-term impact, and not only the individuals, but many systems. And so it's really important that we start to address the issue of mental health and stigma within the Muslim community. Next slide, please. So in order to help people get their mental health needs met, as individuals in a community, we need to take steps to help reduce stigma. And this begins by increasing our awareness about mental health and well-being within our religious context, our historical context, and to help increase our mental health literacy. And it's only when we take these efforts that we can help reduce mental health stigma and promote mental health and well-being within our communities as well. Next slide, please. So what I want to start off with, really looking at it from the religious context. And so what I want to start off with, next slide, some of the common misconceptions people have about mental health. Mental health problems is seen as a sign of weakness of iman or faith. Some people believe that if they were a better Muslim, engaged in more ritual acts of worship, that it would fix the problem. Oftentimes, Muslims may believe that if a person would just strengthen their iman, their faith, they would not have these problems. Now, it's important for us to realize that strong faith is a protective factor in that it may help you cope with the issues you're struggling with, but it doesn't mean that by being a Muslim, you are somehow immune to mental illness. Some problems have biological origins, and when they interact with environmental stressors, it gets worse. For example, depression, schizophrenia, anxiety. And others, especially when they occur in childhood, as Dr. Wang mentioned earlier, have long-lasting effects, physical, emotional abuse, parental death, etc. So, it's really important for us to realize that these mental health issues is part of being human. And that's actually when we look at, and we're going to cover that in a second, when we look at the hadith of the Prophet ﷺ, the sayings of the Prophet, you see so many hadith related to mental health. And the second misconception people often have is mental health is a Western phenomenon, quote unquote. But again, we'll be talking about this when we talk about a lot of the sources and historical legacy, but we know from different companions of the Prophet ﷺ who struggled with mental health issues. Nu'aym ibn Amr, who struggled with alcohol dependence, and yet he was given utmost respect by the Prophet. Muslims have a long history of addressing issues of mental health, and so it's really important for us to realize that many of these misconceptions are in fact misconceptions and not based on truth and reality. And so it's really important that we address these as a community. Another area, misconception, that serves as a barrier for treatment is many people believe the mental health symptoms are due to jinn possessions, supernatural being. While there is evidence from our religious texts about the existence of supernatural beings, we don't know much about this topic. And it's important to realize that most of the symptoms are exhibited and often blamed on jinn possessions are often better explained by mental disorders, and would be a better point of intervention, especially at the initial stages. Next slide, please. So, again, oftentimes people often say that there's no basis. Why are you using, where is psychology? Why is it important? Why do you need to get help? Well, if we just even look at our religious texts, the Quran and the Sunnah, we see over and over again through so much mental health is being addressed and used within our religious texts. So when we look at the Quran, we see that in individuals, that throughout the Quran, legal exemptions are made for individuals suffering from mental illness, depending on the severity of the illness. They may be exempted from fasting, praying, zakah, and hajj. And so the fact that this is something that is addressed is important for us to consider. When we think about the principles of Islamic law, we know that preservation of one's mental health is a major consideration in reaching legal conclusions by legal scholars. And so throughout the Quran and the Hadith, there are numerous verses motivating us to get the help and change our condition. For example, and making sure that we get treatment. And in the Quran it says, إِنَّ اللَّهُ لَا يُغَيِّرُ مَا بِقَوْمٍ حَتَّى يُغَيِّرُوا مَا بِأَنفُسِهِمْ. Allah will not change the condition of a people until they change what is within themselves. And there are a number of hadith that, the Prophet, may peace and blessings be upon him, has shared with us, including there's no disease that Allah has created except that He has also created its treatment. Or every illness has a cure, and when the proper cure is applied to the disease, it ends, God willing. And so there is this richness in our faith tradition that highlights that, yes, there is mental illness, there are disorders, we want to address these issues. We also want to promote mental health. So both sides of the coin are really addressed within our religious text. Next slide, please. And again, not only do we want to address the mental illness, but we also want to seek positive mental health and well-being. And even if we look at the supplications or the prayers or the dua of the Prophet Muhammad sallallahu alaihi wasallam, he encouraged us to engage in additional means of seeking God's help. In addition to doing the work, really asking and leaving it up to Him and helping Him, asking Him to help you in this process. And so this is a famous dua that many people may be familiar with. But what's interesting is the first thing that is being asked, Allahumma inni a'udhu bika min al-hammi wal-hazan. It's, oh God, I seek refuge in you from worry and sadness. And the fact that ham and hazan are used, ham can be translated as worrying about the future, being extremely concerned and worried, can distract you, cloud your mind, make you fear what will happen in the future, what the challenges you will face. And hazan, this can be translated into sadness and sorrow, and particularly sadness about the past. And so you may be frustrated or saddened by something that's happened in the past, or having depressive thoughts and feelings, or about decisions you have made, regret, or losses you've experienced. And that aspects, both anxiety and future sadness about the past, can be immobilizing to the individual. And so again, these are skills that we've been taught to call upon God for protection from these things that may immobilize us. And so again, oftentimes to help reduce the stigma, to really be able to talk about mental health within the religious context, to help destigmatize that process. Next slide, please. So in addition to the religious context, we also have to remember that there is this historical legacy that we have. And so while I shared with you all of the religious evidence of mental health as part of the human experience, what many people do not realize is that Muslims actually contributed to much of psychological thought, diagnosis, and practice. And so we have this rich legacy. And it's important for individuals to realize that many of the modern mental health interventions were practiced that were in the Muslim majority countries before the recent decline in intellectual development. And so for individuals who feel that this is a quote unquote Western phenomenon, no, it's actually very in tune with our legacy. And so I'm going to quickly go through that. If you can move to the next slide. And I'll be sharing some of the work of Dr. Khalid Al-Zamzami and Sadiq Patel, who presented this poster at the Muslim Mental Health Conference last year. Khalid is a researcher at the Family and Youth Institute who's working to help reduce stigma by uncovering historical legacy, and he's working in collaboration with Dr. Rani Awad from Stanford's Muslim Mental Health Lab. And I'm going to quickly go through this, but mainly just to highlight that there is a legacy. For those of you who are interested in reading more and getting access to this, we do have it available. I think we'll be posting it on Facebook and Twitter for those who are interested in actually getting the link, or you can go directly to our website. Next slide, please. And so when we look at, just briefly, when we look at our history, Muslims were active contributors to the field of psychology until approximately the 12th century. Next slide. Part of the problem that we face is that we're currently coming out of a period of decline and rediscovering our history. And so because of that period of decline, we lost that progressive nature and understanding and approach to mental health and well-being. Next slide. And so, here we have different examples of how many of the different principles and theories that are very common right now, commonly used in clinical practice. But these were also discussed and addressed by many scholars in the field within Muslim majority countries. Next slide. And again, the fact that many individuals have discussed the importance of addressing these within the Muslim context, within Islamic history, not only in terms of the fact that we do need to engage in prevention, but understanding the importance of the mind-body connection, as well as how to apply different treatments to different situations and different individuals. Next slide, please. And again, the historical, the first mental health hospital was in the Muslim countries, and the fact that this has been part of our history is something that's well documented. Next slide. Again, medical treatment, different approaches, really trying to understand mental illness, where it's coming from, how to describe it. That's been part of our history. Next slide. Psychotherapy, the importance of cognitive therapy, different approaches, the classification. Again, these are all things that have been discussed, and for those who may be interested in getting more information and engaging in discussion, there's the address of Khalid Zamzami. Dr. Khalid is an individual who's been really working on this issue. Next slide. So when we look, again, knowing the religious context is helpful to reduce stigma, knowing our historical legacy, and then also, thirdly, it's really important for us to have greater mental health literacy. Next slide. And so mental health literacy refers to the knowledge and beliefs that help the recognition, management, or prevention of mental illness. If we can differentiate what normal reactions are from something that's requiring professional help, we can quickly intervene, resulting in a better long-term prognosis. It's important for each and one of us to be aware of this so that it can help us with our basic mental health literacy. And so to address this, one of the things that we do offer, next slide, sorry about that. So one of the things that we do offer at the Family and Youth Institute is that we're trying to provide these tools for you. We do have an email, Facebook, kind of Twitter daily post that really focuses on educating the public on mental health, mental illness, promoting healthy relationships, really bite-sized practical knowledge to empower you on a daily basis. Again, if you need a specific topic, address, you can always send that to our office and we can provide that information to you. We are also trying to share research findings through easy to understand infographics on various topics to educate you on mental health and well-being topics specific to the Muslim community. In addition, we have videos on how to implement this information and provide workshops for more intensive learning opportunities. Next slide, please. In addition to the mental health resources that we provide at the Family Youth Institute, I wanted to highlight a few other resources that I think is very important for us to realize. There is Muslim Wellness has a mental health first aid training workshop that they will come and do to your community. There is Institute of Muslim Mental Health, which has a list of mental health providers. Some are clinicians, some are not. So if you do know some clinicians, please encourage them to sign up on there so that at least there's a place for individuals who want to have clinicians who are familiar with their faith to reach out to them. Mental Health for Muslims is a website which also posts mental health related articles and can be a source of additional information. Specifically to youth, young people, there are two resources that are really helpful. There's Stones to Bridges, which is a place young people can reach out for help online, get questions, answers, and read about their other people's struggles. And there's Amala Hotline out in California for Muslim youth, and they have office hours Monday, Wednesday, Friday, Saturday, and Sunday, 6 to 10 Pacific time. And so young people can call in and get help there as well. And so these are some of the kind of the national resources people can use, but at the same time, there are also local resources in your community that may have a list of direct providers for your area if you yourself are struggling with mental health issues or you know someone who is. Please feel free to reach out to them because that would be helpful. Next slide, please. Okay, finally, in order to make a dent, in addition to us being educated and knowledgeable about mental health, we also need to help reduce stigma in our communities. Next slide. So we need to be able to talk openly and respectfully about mental health issues and really promote mental health and well-being within our community. It's important that we share resources with our family and friends, such as the ones I mentioned earlier. Try to arrange Friday khutbahs or Friday sermons on mental health issues. Encourage mental health programming at the masajids. We're now in a situation where there are a number of different organizations who are willing to come into your community and present workshops. So there's really no reason for the community to not start engaging and increasing their knowledge about mental health. And I think in this process, we can really help to make a difference. Next slide, please. And so as we individually work on increasing our knowledge, it's also important, like I said, to reach out to the community and make that difference. And in that process, together we can make a difference and help reducing stigma within the Muslim community. Thank you very much. Roxana? Roxana?
I think something may have happened with Roxana's connection. So let's go ahead and move forward to our next presenter. This is Ben O'Dell from the HHS Partnership Center on for Technical Assistance. Let's go ahead and move on to our next presenter. I believe that's Imam Sultan. Are you there?
Hello. Yes, I'm unmuted now, so
Yes,
so I hope everyone can hear me.
Yes, we can hear you. Go ahead.
Okay, wonderful. Greetings of peace and blessings. Assalamu alaikum wa rahmatullah. In the name of God, most merciful, most compassionate, all praise is due to the Lord of the universe, and peace and blessings upon our beloved Muhammad and his family and companions, and all of the prophets and messengers who came before. So my name is Imam Sohaib Sultan, and I serve as the Muslim chaplain at Princeton University, and I'm also part of the organization for Campus Muslim Chaplains, the co-chair of that organization as well. So I'm happy today to talk for a few minutes about chaplains and in relationship to mental health. As chaplains, we're at the front lines of mental health in the Muslim community because so often mental health challenges will manifest in individuals or in families as spiritual or relational problems that people often feel are best addressed by the guidance of a religious professional. And so what ends up happening is that when individuals or families are experiencing spiritual challenges or they're experiencing relational challenges, they'll go to a religious professional because that's where they believe that the problems should be addressed if they could not be addressed or resolved within the family itself. And so what we as chaplains do is we offer pastoral care. And pastoral care is helping people with personal problems and families with personal problems from a spiritual perspective using compassionate listening and religious resources. And so we come at it from a spiritual angle, and when people come to us, they're expecting some guidance from within the religious tradition. So we're there caring for someone who is struggling with a difficulty. We are there to be present during a time of pain for individuals and families. And we are also there to pray with someone who is open to prayer during a time of crisis. So really the task of the chaplain is to be a person who is there present at the scene, whether it's in a hospital setting, whether it's on a college campus setting, or any such public institution. Increasingly, we have community chaplains who are working alongside with the masajids, with the mosques, to try to offer this particular specialty as well. Because what distinguishes chaplains and the training of chaplains from the training of typical imams is that chaplains are trained to be pastoral caregivers, that they're trained to offer counsel and to offer advice from a spiritual perspective using the religious tradition, and they are necessarily trained in mental health and mental well-being. So we are not mental health professionals, but we are given knowledge of the major mental illnesses that exist out there and some of the major signs and symptoms. And our job is not to diagnose, but rather to act as bridge builders, which I'll talk about in a moment. You know, I think that moving to a very personal encounter and experience with mental health as a chaplain, one of the things that, you know, I would echo what Dr. Samira had to say earlier, which is that oftentimes when people will come to me as a chaplain with the various challenges they might be facing, you know, first and foremost, for a lot of people, they're not convinced that what they're struggling with is a mental health issue as opposed to a spiritual problem. And so oftentimes, as I said earlier, it'll manifest as a spiritual issue. And after a little while of talking with an individual, I might be able to say, you know, this is not a purely spiritual issue. This is something that very much would require a mental health professional. And sometimes it's hard to convince people that, that the issue they're facing goes beyond spirituality and goes even beyond necessarily the resources that we have purely within the religious tradition. So that's one of the challenges when we're talking about the stigma of mental health. That's one of the challenges. Another challenge is that even once a person is convinced that that what they're facing or what their families are facing is a mental health crisis as opposed to a spiritual one alone, then they're very much concerned about finding the right culturally competent counselor. And there's a lot of fear that if they go to a counselor, they're not going to understand Muslim culture, that they're not going to be sensitive to the Muslim, Muslim values and virtues that the individual, the family might be aspiring to. And so there's a lot of there's a lot of hesitancy in seeking mental health help from especially non-Muslim counselors, and so that's another aspect of the stigma that I often have to challenge. Interestingly, in this age of anti-Muslim sentiments and rising Islamophobia, that's also a challenge, because so many times when I talk to individuals, they mention that people already have such a bad reputation of Islam. They already have so many misunderstandings of Muslims, and the last thing that they want to do is go and speak to someone about a problem that they're facing that might, through them, indict other Muslims, in terms of perception issues, or they might have to talk about their community or their culture in a way that is not necessarily the most positive. And so how will that feed into the larger problem of anti-Muslim sentiments and Islamophobia? And so this is another very interesting stigma that a lot of people who come to me face and are very hesitant to go to a mental health professional about, for these reasons. But as Dr. Samira was saying, there are many evidences from both the Quran and the prophetic tradition, the Sunnah, that seeking help for one's mental health and for one's anguish that they might be internally feeling is very much in line with our tradition. And so in addition to what was mentioned earlier, I think what's very interesting is that if you look at the Quranic narrative, you'll find that so often you find that God is in fact consoling and, if you will, offering mental health well-being to the Prophet Muhammad, peace and blessings be upon him. So you have passages in the Quran where God is saying, your Lord has not forsaken you, right? So there's this idea that people sometimes feel very lonely, they feel like totally abandoned, and that's as much of a psychological state as it is a spiritual state. And so this reassurance from God, not only to the Prophet Muhammad, but to all who ask this question of whether they've been abandoned, there's this beautiful verse that says, your Lord has not forsaken you. You have another verse or passage in the Quran where it says, with every hardship comes ease. And so sometimes when people are going through difficulties and challenges, it's so hard for them to ever be able to envision any light at the end of the tunnel. And here again we have God saying, with every hardship comes ease, giving reassurance not only to the Prophet Muhammad but to all who read the scripture. And you also have the story of Yaqub, or Jacob, peace and blessings be upon him, in the story of Yusuf, of Joseph, peace be upon him, in which God says that Yaqub's eyes turned white. Basically, they turned blind out of crying and crying and crying out of a real loss for his son Joseph. And so we see that a prophet of God is suffering from real grief, from real mental anguish at the loss of his son. And that's another example of how mental health and psychological the psychology of the human being, even of the prophets, is being mentioned within the scripture. So what I would like to emphasize is that chaplains are at the front lines of offering mental health services, and if one is experiencing any sort of internal anguish, it is a good idea to go and speak to a chaplain to get their advice, to get their input, to seek their counsel. And ideally, the chaplain is the one who can sometimes, or hopefully not just sometimes, but often be the bridge builder between individuals and families within the Muslim community and mental health professionals. And so I'll end with offering just one story from my own experiences. I could offer many stories, but one experience that really strikes me as important to share when it comes to this idea of chaplains acting as bridge builders to the mental health professional community, is that once, at 11 o'clock at night, there was a sister from the community who called me, and she asked in a voice of desperation if she and her family could come and pay me a visit in my home. And she said, I know it's very late at night, but I would really appreciate it if you could just allow us to visit you and to talk to you personally about a problem that we're facing. And she says that I would never do this if it wasn't such an emergency. So of course I wanted to be helpful, and so I consulted my wife, and we decided to invite them over to the house. And so almost around midnight, this person came with her family, and the situation was regarding her brother. Her brother had been for some time now hearing voices and experiencing some real mental anguish and depression and sadness, and a loss of a feeling for the value of life itself. And he said in front of me when I was talking to this individual that that sometimes he didn't understand the reason for living on, and so he struck me as somebody who might be suicidal. And I remember in my training as a chaplain, knowing the signs of somebody who might actually be suicidal versus somebody who is just using the rhetoric of death. And so I saw these signs in the individual, but still, as a chaplain, because again we're not mental health professionals, I didn't quite know what the next step might necessarily be. And so I called a friend of mine who is a mental health expert from the Muslim community, and I told them of the situation, what this individual is going through. And this the mental health professional that I reached out to, she said it was very important for me to speak to the individual and ask 3 really important questions about their particular comment on suicide. The first question was, when was the last time he contemplated suicide? And the second question was, did he have an actual plan for committing suicide? And the third question was what was there that was actually stopping him from committing suicide? And so these 3 questions, when I asked him, they all turned out to be red flags, meaning that the last time that the individual thought about suicide was very recently. The person had an actual plan, and what was stopping them was not very convincing, nothing very convincing at all. And so immediately the mental health professional and myself, we understood the how dangerous and how grievous of a situation this was, and we immediately got the emergency services involved and got this individual professional medical care immediately. And so the reason I highlight this story is because mental health is not simply a matter of convenience. Sometimes it is something that is really life-saving. It's not a luxury. It is oftentimes an absolute necessity. And if we as a community don't take it seriously, and if we as a community don't reduce the stigmas around it, then we're not only risking people's mental health and their happiness, but also even perhaps their own lives. And so that was a real learning moment for me that I wanted to share with all of you. So I look forward to the questions and to continuing the conversation. Thank you so much for listening.
Thank you, Imam Sahib Sultan. I'm back. This is Dr. Roxana Chaudhry. Lost connection for a moment, but I was able to hear your entire presentation here, and I think that sets us up well also for Miriam's story, that she is really giving us the privilege to hear where we can understand the more personal effect of someone with a mental health struggle and how they came through that by tackling stigma within their own community, and even as she continued by becoming a peer counselor and furthering work to work with others in the community. So we now turn to Miriam Abdulaziz.
Thank you, Dr. Chaudhry. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم السلام عليكم ورحمة الله وبركاته. I greet everybody with the greetings of peace, and like I said, I'd like to thank you, Dr. Chaudhry, for the introduction into and all the associated organizations that put the webinar together. It's great to be on a panel of such knowledgeable people in their field and their expertise. And I'm very excited that this conversation is happening within the Muslim community and beyond. It is very important to have this conversation. As Dr. Chaudhry said, I'm not a scholar or an imam, but I am a person with a lived experience of a mental health condition. And while I do have some professional credentials, I think that my lived experience is an additional perspective and voice that needs to be heard. And for my story, there are countless people out there with similar experiences. And I am here to say that wellness and recovery from a mental health condition is absolutely possible. Of course, with the mercy and the guidance from Allah subhanahu wa ta'ala. I'd like to start by just sharing a little bit about my personal story. After a very carefree childhood, I reached my teens and things became a little bit more complicated. I experienced several events in my life that led me to have a feeling of loss. My parents went through a divorce, and I graduated from high school and left close friends behind. I also went from a very small, close-knit high school to a large university, and I really kind of felt like a fish out of water. I really didn't know it at the time, but those three things happening so close to each other, those events kind of affected me as if a trauma would affect somebody. And I went on to start having some symptoms that started off very slowly and subtly, but they became increasingly worse and worse. And what I'd like to say is that when I describe how I was feeling, I'm going to stay away from clinical terms because I'm going to use something that I like to term human experience language. I think that these terms, because with clinical terms they mean something different to different people. For example, if you say depression, it might mean one thing for one person and one thing to somebody else. For me, the symptoms came as a feeling of deep sadness, feelings of loneliness, even when I was around people, feeling detached or emotionally empty, frequently crying, negative thoughts. And eventually, as it progressed, it got really to the point where I didn't really want to get out of the bed, or got to the point of needing assistance with everyday tasks because little things seemed very overwhelming for me. Then kind of on the flip side of that, there were also times where I felt revved up, I felt anxious, I had a lot of racing thoughts, so there was a lot going on in my body and my mind. I spent years living this way, where I was functionally depressed, basically holding down a job, but feeling, very empty inside. And until I was able to realize it and help and get the help from others and get the assistance that I need. Eventually, I did end up in the hospital where I stayed for 2 months, where I was being kind of quote-unquote stabilized, being brought back into balance. And that it was there that I was given the diagnosis of bipolar disorder. For me, my bipolar disorder ranged more on the side of depression. I did experience kind of mania, but really majority of it, I would say 80% of it was on the side of depression. And although for many a diagnosis is a daunting thing, and it may feel like the end of the road. For me, I had a little bit of a different experience because it allowed me to put a name to the experiences I was having, and I was able to then educate myself about it and seek assistance. My diagnosis now was over 15 years ago, and a lot has happened since then because I was blessed enough to receive the proper assistance and support. I have gone from feeling depressed and hopeless and sad and overwhelmed and not being able to function to being a wife. And I want to say that I've been married for 13 years to a wonderful, alhamdulillah, man who knew about my condition before he married me and married me anyway. Also, to graduating from college with honors and a degree in, ironically, psychology, to being a mother of two very energetic and loving girls, to becoming a certified peer specialist, which is a person with lived experience who is dedicated to helping others, of spreading hope and wellness and letting people know that recovery is possible, to becoming a whole health and wellness coach, and to be a co-director of the Certified Peer Specialist program for the state of Georgia. And also to being on the executive staff of Aziza magazine, which is a magazine for Muslim women who's been in existence for over 15 years as well, and to becoming an advocate for mental health awareness. Now, I say all this not to shine light on my accomplishments whatsoever, but instead to show the power and mercy of Allah subhanahu wa ta'ala and how he can change situations. In the Quran, human beings are described to be created in the best of molds. And it is important to understand that when you encounter difficulty, that at first glance it may not look like the best of molds, but Allah subhanahu wa ta'ala makes no mistake. We are all on a spiritual journey, and we don't know where we're going to be led or why, but we continue to ask for guidance. We really have to be careful in the faith communities, especially when people are having types of issues. Many times this is a debilitating experience and something that people cannot just snap out of it or will themselves out of it. And many people say you're told to pray harder or have more faith, and some people are even say that it comes from bad spirits or from shaitan. But mental health conditions are often misunderstood. We don't tell someone who's dealing with a physical health condition such as cancer to snap out of it. And like any other condition, it is one that needs to be properly understood and managed. And we really have to work on reducing the stigma and shame associated with dealing with emotional difficulties. Like Dr. Samira said, many of our brothers and sisters are suffering in silence because they can't be open about what they're dealing with. What I have learned is that all of us have challenges and tests we go through. And Allah has a way of turning the most challenging of trials into the most beautiful of blessings if we only patiently persevere. And as Muslims and other people of faith, it is important to realize that God is the ultimate judge and that we should refrain from judging both ourselves and others. And instead, we should rely on God or Allah for ultimate guidance, direction, and forgiveness. I just wanted to also say that as people of faith and as Muslims, in every day when we pray, we recite from Surah Al-Fatiha, which reads, Bismillah, Iyaka na'budu wa iyaka nasta'in. You alone do we worship, and you alone do we turn for help. And as in this ayah, it describes that prayer and seeking Allah's guidance is essential and necessary. And the fact is that when you pray, Allah sends you ways to solve your issues, and it may look different than you expect. It is important to realize that the guidance may come in different forms. It may come in the form of support through family or friends or care providers. It may come in the form of an expression, such as art or photography or writing. it may come in the form of therapy or vitamins or medication or holistic practices. It may come in the form of a listening ear or an inviting smile. So it's important to let people know that there's a lot of support out there, and you just have to know where to get it. And there was a lot of great resources that have already been given. I would like to say that I know I do not suffer from a mental health condition or mental illness. I like to say that I live with it because that's what I do. I live with it on a daily basis. And like anything else, it can be properly managed and with the right support system. One of the great support systems that helps me is something called the Wellness Recovery Action Plan, which is basically a plan that you put together for yourself that keeps you balanced and as possible. It includes your daily maintenance plan, things that you do to stay well. It also includes triggers, which would be things that might get in the way of you being well. Early warning signs, so you can keep an eye off on the things that might come your way. And then it goes on to talk about a crisis plan for when you are not well, so that your supporters, you do this when you're well, so that your supporters can help and assist you when you're not well. And then it ends with a post-crisis plan. I just want to say that the stigma of mental health can be a very hurtful thing. And sometimes people, you know, have stigma because of fear, or because if a person doesn't understand something, that they become afraid of it. There's an unfamiliarity that causes an uncomfortable feeling. There's a lot of things in the media of people with mental illness, and the actual fact is people with mental illness are more likely to be the recipient of some type of violence than the perpetrators. So there's just a lot of myths out there and stereotypes that we need to think of. And see here. I just want to say that it's really simple. It's treat the others in the same way that you'd want to be treated, because one is dealing with a mental illness or a mental health condition does not make them any less human. It does not make them any less intelligent. It surely does not mean that they're not in tune with their own feelings and their own wants and needs. And if you are a provider, listen to your client. What are they expressing? How can it be of assistance and service to their wants and desires? You play a critical role in their care. Choose your words carefully and your ways of interaction carefully. There's countless people who have come to me in the work that I do saying that they were told that they could never work again, that they could never have a family, they could never, you know, they could never go to school. And I know if they weren't depressed before that, they would surely be depressed after that if nobody had any vision for them. If you are their friend, be understanding, listen, express support, just be there. If you are their parent, remember your son and daughter as a child, and remember that innocence that they carried and that joy that they brought to you. That person is still there. Be there for them, advocate for them, care for them, love them. I want to just kind of close by saying that well, one thing I want to say is there are many stories of recovery. I know people who have been hospitalized for years who are now running organizations. I know people who have been homeless who are now doing amazing things. Adversity happens in the blink of an eye, and I just want to close with an image of maybe a tree in nature. And what I want to say is we all go through seasons. So in the fall, the leaves of the trees are colorful and beautiful, and you see different shades. And then in the winter, it's barren and it almost looks dead. In the spring, there's flowers, and then in the summer, it's flourishing. And through all these times, we're the same. Like trees, we have cycles of development, and we are the same people, and we have goals and dreams and desires. And so it's very important that we would treat a person who looks like they're barren in the same way that you would treat the person who is flourishing. But I want to close out by saying recovery is possible, and I know we have to get to questions, so thank you.
Thank you so much, Miriam. That was a very passionate and I think profound telling of your journey and how we can actually utilize that in whether we are a professional in the area or someone that is dealing with mental health issues themselves or struggling with that or someone they know. We are close to the end of our time, and I want to be aware of that so that we can receive 1 or 2 questions at least before the time does end. And there is one question that I think I would like to pose to the whole panel, and perhaps those panelists that would like to answer and participate in the question in some way will be able to do that or may not. But I think it does apply to everyone in how you might view this question. So Alia asks, how do you gently or effectively encourage a person to seek help for their struggle with mental health, considering they may be unaware or in denial of their own state? Considering that we are talking about stigma, I find this question to be relevant to all of us here on this panel. So I'd like to ask anyone on the panel who would like to contribute to that.
This is Samira. So that's a really common issue that comes up. And I think some of the times I would kind of talk to the individual and ask, how is it working for you now? They may be struggling with the issue and they keep doing it more of the same, and if that's not working, are they open to trying something else? And what are the different things? Now, in the process of that conversation, if they're hesitant about seeking mental health because of the stigma, one of the examples I'll use would be a medical model and say, if someone's got diabetes, situation is not going to get better unless you take the medication. If someone's got asthma, and really helping to use those analogies to help reduce that stigma and say, things aren't going to change until we do something about it, and really being there for them and helping address their needs. And if it's finding culturally competent clinician, helping make that connection for them, helping them with sometimes getting the motivation to get that need, because sometimes people don't realize the long-term impact of these issues, and helping them realize if they don't get help, how much worse it can get.
Thank you, Samira. Would anyone else like to add anything to that?
This is Imam Sohaib.
Sure.
One thing that I wanted to mention was that in my experience, a lot of times it's really challenging to get people who need help the most to actually go and speak to a mental health professional because they think that they are being singled out by their community or by their group of friends or by their family. And so sometimes it may be a stigma for sure, but sometimes it's also something that people take very personally. Oftentimes you'll hear people say like, do you think I'm crazy? They use negative terms like that in response to people's suggestion, even loving suggestion to seek a mental health professional. And so I think that one of the ways of thinking about it is that, if there's a way to take someone to a mental health professional and to go with them and to say that, this is something that I need, or this is something that we need as a family, Sometimes when people feel like they're not being singled out, but rather it's it's group therapy of the family or of a group of friends, then the individual might be more willing to go along. But I have found again and again that oftentimes the biggest challenge is that the people who need the most help are the most resistant often to going to seek that help. So that is a big challenge that I think we all face as advocates.
Mm-hmm. Thank you, Soheb. I do hear that often as well myself, and I think one of the purposes of what we did tonight here and hopefully achieve through the feedback of the listeners that we will receive later on is that just bringing together different groups and individuals who are willing to tell their story like Miriam has a powerful effect, I think, on encouraging others to receive treatment, something that I've heard in different places that I've worked and trained and taught in. So I want to commend all the panelists today for giving such deep content to this issue, and to Miriam for being brave and being able to tell her story in a large audience like this, and hopefully that does inspire others to begin to think about whatever it is they might struggle with, or whoever is in and around their community and families. And I'd like to thank Dr. Wang who joined us from SAMHSA, Division of HHS. Finally, I'd like to say thank you to all of our partner organizations, AMPS partner organizations here that you see on the PowerPoint. I know that this will be, this presentation is recorded, so you will be able to access this later on. And I'd like to thank all of our listeners for their participation, whether it was through questions or just listening, and for tuning in. And hopefully this does inspire others to begin to tackle this issue in their own community. So thank you to everyone. And that's all the time we have for tonight. Thanks again.